blood pressure is systolic over diastolic. There are two numbers that we calculate there. Systolic is the pressure during ventricular systole. Diastolic is the pressure during ventricular diastole. And when you take a blood pressure, basically what you do, there's an artery that sits right under the biceps right here. If you stick your finger in there and roll it around, you can feel it moving around. And that's the brachial artery. And essentially when you take a blood pressure, what you do is you put a cuff on the brachial artery, you inflate it to a value that's sufficient enough to collapse the artery, usually about 200 millimeters of mercury or something like that. You just pump it up. And you put a stethoscope right here on the artery in the antecubital region, and you listen. And you can't hear any blood moving through there, right? So when you pump this up and collapse the artery and you have a stethoscope right here, you don't hear anything. Then you slowly let off the pressure of the cuff. And at some point, you'll start to hear blood begin to move through this artery in the anterior region right here. And that's the systolic pressure. That is the force being generated at the point that has opened up that artery above the cuff, and you start to hear blood moving through. So that pulsing of blood moving through the artery is what you hear when you take a blood pressure. Then as you keep letting off the pressure, eventually the pressure in the cuff is equal to the pressure while the heart is at rest, and you no longer hear the blood moving. And that's your diastolic pressure. So what you're looking for, or I guess what you're listening for, when you take a blood pressure, is what is the value when I first hear blood moving, that's systolic, and what is the value when I stop hearing the blood, that's the diastolic. You'll start to see the needle moving, just due to the elasticity of the vessel, before you hear it. And that's your kind of signal that like, oh, I better start listening pretty carefully. Because it's not when the needle moves and stops moving, it's when you hear it and stop hearing it. So there is a skill to taking a blood pressure. I would recommend practicing before you actually start doing the experiment so you're comfortable taking the blood pressure. The blood pressure cuffs are over here. First of all, make sure that when you take one out that it's set at 0. And if it's not, we won't want to use the cuff. Sometimes we have to recalibrate these routinely because a lot of people use them. So make sure that it's at 0 before you start. Here are stethoscopes here. They're cheap, but they work fine. Sometimes it's hard to hear. The room is kind of noisy, but just do the best you can. You can clean them with alcohol pads here if you want to, clean the ear things and whatever for that. So practice at some point. The first thing you're going to want to do, or as you do this, is practice taking blood pressures and heart rates, because that's the values we want. Okay? From the blood pressure, we can get the pulse pressure. And what's interesting about the pulse pressure is the difference between these two values is the force with which blood's ejected from the heart. So the difference between systolic and diastolic is that pressure pushing blood out. So it is our estimate of stroke volume. The higher the pulse pressure, the more blood is going to be pushed out. We can't correlate it millimeter of mercury per milliliter or anything like that, but there is a relationship. So if your pulse pressure goes up, your stroke volume goes up. If your pulse pressure goes down, your stroke volume goes down. Okay? And then we also know from systolic and diastolic we can calculate the mean arterial pressure. That's just the diastolic plus 1/3 of the pulse pressure. And that gives us an idea of what is the average pressure in any artery independent of where you are in the cardiac cycle. Right? It doesn't matter whether you're in systole or diastole, what's just the kind of average pressure that's there. So once you do the blood pressure, these two are just calculations from the blood pressure. And then respiratory rate is just breaths per minute. That's actually, interestingly enough, difficult to do. The easiest thing to do is to listen for it. If someone has a stethoscope and they put it on the back of the person, they might be able to hear the air moving. You can put it on the throat of the person and hear the air moving when they breathe that way. Or you can just ask the test subject to count their own respiratory rates. The problem with that is that they will always slow down their breathing when they count. Okay, but it's the best we can do, right? As soon as you concentrate on counting or something, your respiratory rates go down. So, it's the best we can do. So try to figure that one out, how to do the respiratory rate, but that's in breaths per minute. So heart rate, manually, blood pressure there, and respiratory rate. Easy to calculate manually. The other thing that I want while we're doing this is if the heart rate changes, I want to know how did it change, right? We know that this is a typical, if we were doing an EKG, right? This is a typical EKG tracing. I'll just put 2 heartbeats on here, right? something like that, right? And we know that we labeled this, when we look at it, you know, P, Q, R, S, and T. That's one cardiac cycle, right? P, Q, R, S, and T. That's another cardiac cycle. Now these are electrical events that correspond to depolarizations and repolarizations of the ventricular myocardium. P is atrial depolarization, which causes atrial systole. QRS is ventricular depolarization, which causes ventricular systole. And then T is that ventricular repolarization or resetting, and that's what is correlated with ventricular diastole. All right? So all of these is a heartbeat. Atria contract, atria relax. Ventricles contract, ventricles relax. That's a cardiac cycle. And then there's another one. Now, if the heart rate changes, this pattern has to change, right? If the heart rate goes up, things have to get closer together. This is what we're hearing when we hear the heart rate or whatever is measured, is we're hearing the ventricles contract or feeling the ventricles contract when they contract. So we know that these have to get closer together when the heart rate increases and further apart when the heart rate decreases. So the question is, where does this change? Now I'll tell you, we know this, right? You guys certainly know that what starts all of this is when the SA node fires. So at the beginning of P, what does start all of this is when the SA node fires. So through parasympathetic and sympathetic stimulation, you are going to change when this happens after this. So this interval right here is going to change whether or not this is parasympathetic or sympathetic stimulation, right? So this interval right here, I have every expectation that when we do an experiment on heart rate, if the heart rate changes, this changes right here. This is called the interbeat interval or the TP interval. It's the time in between heart rates, or in between cardiac cycles. So if we have sympathetic stimulation, this happens sooner. If we have parasympathetic stimulation, this happens later. So we would expect that interval to change. But there's nothing that says this interval can't change either, right? Something in here. Maybe as the heart rate increases, to allow it to beat faster, the ventricles have to repolarize faster. So maybe this interval changes here. Right? That would be called the QT interval. Right? Maybe that can change. Maybe things come faster or slower to reset things. The duration of the ventricular contraction, the QRS interval. Maybe that can change. Maybe things can happen to make that signal